So first we will discuss about one case, small case. Then we'll start with the sources, that what sources you have to be worried while discussing about the OP compounds. Then coming to the mechanism of action, clinical features of OP poisoning, then examination findings. All right. So let's start. Okay. Wait just a second. All right. So we have a 32-year-old farmer, basically, who was brought to the emergency department by his co-workers after he was found unresponsive in a field. His co-workers report that the patient had been spraying pesticide earlier the day and he was found to have difficulty in breathing. So there is obviously, these are all signs of cholinergic excess, right? So patient has excessive sweating, salivation. There has been history of asthma in this patient, but no other medical problems. And the vitals, as you can see, patient is having hypotension, bradycardia is there, right? Respiratory rate is very high, oxygen saturation at 88%, right? So in this condition, what physical findings, what physical examination findings you might see? Okay, so we have everything is mentioned over here. So general appearance will be patient is having unresponsiveness, diaphoresis, pinpoint pupils were there, and all these findings were collectively there. So this is just an overview that how the patient will come to you. Typically, there will be history of either insecticide, pesticide spray, or with the help of suppose if patient want to do suicide. So this can be one way that he will do. Mostly in the rural population, you might see this condition. Okay, so this is the first easy MCQ just to have an overview that in such condition, what do you think about? So we have to get to the diagnosis because we are obviously discussing OP poisoning, right? So, but these are the close DDs which are related to the OP poisoning, guys, because myasthenia gravis is a neuromuscular junction disorder, right? So definitely patient has muscle weakness, which can similarly occur in patients of organ phosphorus compounds. Talking about Guillain-Barré syndrome, so Guillain-Barré syndrome, patient might have neuropathy, or again the descending muscle weakness, which is very common in case of OP poison complications. Because OP poisoning has two main complications. First is called as intermittent syndrome. The second is OPID, that is opioid-induced delayed neuropathy. In that, it might mimic as a Guillain-Barré syndrome. Then botulism is one of the DD for the descending paralysis, which can be seen in intermediate syndrome. Then acute asthma exacerbation, as the patient has a history of asthma also. All right. So that's about the basics. Now let's start with the introduction. What are the things that can be seen as OP compound? So most important is agriculture pesticide. All right. So agriculture pesticides are parathion, malathion, chlorpyrifos, and diazinon. Okay. So these are quite potent. Definitely they are potent, and they can lead to all the cholinergic excess symptoms. Right. Coming to the nerve agents. Then in nerve agents, we have all the drugs which can be used as a chemical warfare. So you might have read about that in FMT and all also, but this is important. Sarin, soma, and taurine. Okay, so these are some of the nerve agents that you should be aware and which can be used as a chemical warfare, right? Then coming to the household insecticides. So this is dichlorobas, phenytoin, and phosphate. So if you're living in metro countries, you might see this type of common poisoning cases. But always remember, and these are obviously very less potent and as compared to the agriculture poisoning. Therefore, you don't have to worry at such, and you have to just reassure the patient. But if at all, if patient's responsiveness is not good, you might see some serious complication even with the household insecticides. Okay. Okay. Then we have other industrial applications. So industrial applications, mostly we have trichloroform here. But remember, this again has low potency as compared to the agriculture pesticide. So most important and most common is agriculture pesticide as the commonest cause. Okay. Okay. Then coming to the next part. So that's about the all the sources which can be possibly lead the patient to the OP poisoning. All right. Then in OP poisoning, there is very one important concept that how the OP poison acts. Okay. So this is the chemical structure of the OP poison. So as you can see, I'll just zoom it a bit. Okay. As you can see, this is a serine end. Okay. Which is very important for us because to the acetylcholinesterase enzyme. Okay. So this OP poison gets attached to the acetylcholine enzyme. Okay, so ACHE plus OP occurs at this serine end. Okay, so always remember this part. So because of this, we have this bond over here. Check out this bond. Okay, so this bond is available for the hydrolysis. And if there is a hydrolysis of this bond, that is, if it gets replaced by the OH, then this process is called as aging of the acetylcholinesterase enzyme. So why this is called as aging? Because aging means this enzyme will completely get inactivated. Okay. So why does it occur? It occurs because of the hydroxylation at the R2O end. Okay. Because the serine end is occupied by your OP poison. And in a similar manner, what is the antidote for the OP poison? Anybody? I know you are so smart. Just tell me the antidote for the OP poison. Anybody? Quickly. Atropine, very good. The first antidote is always atropine, but the specific antidote, if you talk, which can reverse this aging process, or rather than reversing this aging process, once this aging process has happened, it will not get reversed, but which will prevent this aging. That is PAM. Very good. Somebody has mentioned. So pralidoxime. Okay. And how does it prevents the aging? So it basically acts at this serine and will lead to conformational change in the enzyme, and because of this acetylcholinesterase again get activated, okay, leading to the metabolism of whatever acetylcholine we have in the neuromuscular junction. Okay, so this is in a brief. I will just tell you again. So suppose if this is the neuromuscular junction end. Okay, okay, all right, here we have ACHE. Okay, these are ACHR receptor, your ACH receptors basically. Okay, we just reduce the thickness of the spine. Okay, so this is your ACHA. So what will happen? Whenever the OP poison compound will come, it will join to this ACH plus OP. Okay, so it gets inactivated. And because of this, whatever acetylcholine it's coming over here will get stored over here. Got it? So it will get stored over here in this space. And that's, dear friends, is called as cholinergic crisis. Okay, so whenever we have acetylcholine in excess, we know it definitely will act on the three receptors. Okay, so first is your muscarinic receptors, right? Second is your nicotinic receptor, which mainly acts on the muscles. Okay, and third is your CNS receptors. Okay, so starting from depression, anxiety, coma, anything can happen in the CNS, which we're definitely going to discuss. But right now, you just have to understand why this inactivation was occurring. But if we give PAM to this patient, it will attack the OP and freeze the acetylcholinesterase enzyme, which will eventually start again destructing or metabolizing this acetylcholine, which was excess. Okay, so this is about the mechanism of the acetylcholinesterase and about the OP compound in a nutshell. Okay, so coming to the next part. So what is the mechanism of action? So as I've already explained, so inhibition of the acetylcholinesterase enzyme occurs by binding to the serine end. Okay, serine end of the your acetylcholinesterase enzyme. Okay, so this serine end is present on the OP compound, which eventually binds the acetylcholinesterase enzyme. Okay, so that is the mechanism of your OP compound, right? Just a second, guys. Sorry. Right. Then there is, because of this, there is an accumulation of acetylcholine. And as I mentioned, this acetylcholine, okay, as I mentioned, this acetylcholine will act on muscarinic, nicotinic, and CNS. Okay, so that's about the mechanism of action of the OP compound in a nutshell. Right. So I have one MCQ for you guys. Can anybody solve? So if this patient is diagnosed with OP poison now, okay, OP poisoning. Now, what should be the next best step in management of this patient? Anybody? Somebody has mentioned C, Kunal. So Kunal is absolutely correct, guys, because atropine is the first step once you get the diagnosis. Obviously, for confirmation of the diagnosis, you might need RBC cholinesterase level or plasma cholinesterase level, but atropine is the correct answer if it has been asked like this in exams. Okay, why? Because you have to start with atropine to reduce the symptoms of the patient. Because of all the muscarinic symptoms, patient is already in the debilitating condition, right? That will cause bronchuria, bronchospasm. Patient will have meiosis, right? Patient will have all the symptoms which we're going to discuss. So that is called as toxidrome. So toxi plus syndrome, that is toxidrome. Okay. So let's discuss the toxidrome of OP compound. Okay, so what are the symptoms? Just remember by the slurge mnemonic. Okay, S is for salivation. As you know, because of excessive acetylcholine, all the secretion in the body will activate. Okay, only negative effect of the SEH will be on the heart. Okay, that will cause bradycardia. Apart from that, all the things will be tachy or increased. So salivation will be excessive, lacrimation will be excessive, urination will be excessive, defecation will be there because of increase in motility of the gut. Then gastrointestinal upset might occur, leading to nausea, vomiting, abdominal cramps. All right. And then we have emesis again. So all these things are increased. Again, this bronchuria is increased secretion from the respiratory mucus of the respiratory mucus. Then bronchospasm and wheezing are some of the symptoms of the same toxidrome. All right. Lastly, bradycardia and hypertension. So the only thing you have to remember is bradycardia. Rest of the things is only increasing, right? So that's about the muscarinic effects. And where do we have the nicotinic receptors for the acetylcholine enzyme? So that typically are on the muscles. So what will have muscles will have fasciculation, muscles will have weakness. Okay. So what are the negative nicotinic effects? So we have muscle fasciculation, we have muscle weakness and paralysis, and we have tachycardia. Okay. So this can happen due to the nicotinic receptors sometimes, tachycardia. But most commonly patients are in the brady only. Okay. Then CNS effects. As I mentioned, in CNS also you will see confusion. Most common seizures is very important. So in this condition, if seizures is there, then BZD will be there. Okay. Then coma and respiratory depression. Yes. Okay. So this muscle weakness and paralysis is mainly because your neuromuscular junction, right? And definitely whenever you have neuromuscular junction involvement, that is your element pathology, right? You remember this, everything starting from your cranial nerve, then to basically the nucleus of the cranial nerve, okay, to the anterior horn cells. Then again, talking about the muscles, neuromuscular junction, nerves. This has to be element pathology, right? And if you're talking about the tracts, that is from anterior horn cells, then dorsal column, then coming to the all the neuromuscular junction, nerves, versus and muscles. This is lower motor neuron. So in all the lower motor neuron, we will have flaccid weakness. Plus, you will also have muscle fasciculation. That is very important. If you remember in lower motor neuron diseases like amyotrophic lateral sclerosis and all, amyotrophic lateral sclerosis is basically UMN plus LMN, but LMN essentially mostly seen in the neuropathies, and element disease typically are like this neuromuscular junction, myasthenia gravis, and even OP poisoning, that too only in case of intermediate and OP induced neuropathy. So if this happens, you will definitely note the muscle fasciculation, but always remember that there are also tongue fasciculation which has to be noted. Okay. So this is about the muscarinic, nicotinic, and CNS effects. So you guys got it? Then coming to the next question. Now, okay, we have administered atropine and pralidoxine, and patient's respiratory distress is also improved, but muscle weakness is persistent. Okay, so what to do? And 48 hours later, the patient develops severe proximal muscle weakness. Okay, as you can see, severe proximal muscle weakness is there. So now what to do? Along with that, we are getting it difficult to wean the patient from ventilator. And considering there was one history or one episode of fever, okay, if patient had one history of fever, then your diagnosis completely changes in this case, right? But here there is no history of fever. You can see there is no history of fever, nothing over here. So guys, just remember, now let's discuss the complication. The duration given over here is how much? It's just 48 hours, isn't it? Okay. So what's the issue with this? Okay, so duration is how much? 48 hours. If the duration would have been more than 1 week, then your answer would have been correct. That is OP-induced delayed neuropathy. So this is not delayed. This is something just intermediate. Okay, so let's discuss about the complication. So we have, most importantly, in acute cases, we have acute respiratory failure because of obviously neuromuscular junction involvement, plus because of the CNS depression. Okay, so obviously there will be respiratory failure, particularly type 2 respiratory failure is seen. Okay, what is type 2 respiratory failure? So type 1 is hypoxemic, type 2 is hypercapnic. Got it? So because of this respiratory failure, your respiratory muscle will get weak and they will not ventilate properly, and because of that hypercapnia will occur or increase in PCO2 will occur. Okay, and in this patient definitely we have to intubate the patient, right? So that's about the first important complication, that is acute respiratory failure. Talking about the intermediate syndrome, guys, so we had one case. So basically patient was admitted in the ICU. Okay, he had OP poisoning history. It was a suicidal attempt, and then he came, then he was in the ICU itself. We shifted him to the ward, and within just 1 day, his neurological condition worsened. He started having proximal muscle weakness, to be specific, but his reflexes were normal. We were just wondering that if it's GBS or what, but reflexes are not present. That means if it is areflexia, that could be GBS, right? But here the reflexes were normal. So we just thought that exactly what it could be. So we did NCV. Okay, and NCV was also normal. So actually, this case was nothing but intermediate syndrome. Okay, so patient typically presents within 48 hours. Okay, patient has muscle weakness. Okay, and some of the time patient also has respiratory muscle weakness. Okay, or respiratory failure or respiratory depression, and because of this, it becomes really difficult to wean the patient from ventilator. All right. So this patient has muscle weakness, and it was really difficult for us to win the ventilator from ventilation. But the real question was why the intermediate syndrome occurred. All right. So we will discuss about Gayatri's question in while discussing the treatment. We are just discussing complications with symptoms. Then we will discuss physical whatever clinical findings we can see, and then we'll come to the laboratory investigation, then treatment. Okay. So talking about the complications, intermediate syndrome, patient will have proximal muscle weakness, to be specific. Remember this proximal word. This is very important. Okay. So it is proximal first, then distal. So it starts with the proximal muscle weakness, but why it occurs? So guys, if during course of OP poisoning or during worsening of the patient, distribution or redistribution of this OP poison occur in the fat tissues. And if you have not given palidoxin, then what will occur? Aging will occur, right? And because of this aging effect and this palidoxin and this OP poison was redistributed to the fat tissue. But gradually, as this again starts coming into the circulation, the symptoms start to appear about the OP poison, and that's about the intermediate syndrome. But this is just a theory. As such, it is not given in the book that this is the exact mechanism. That's why you have to be a little skeptical. But yes, if you want to tell yourself that how it occurs, so it occurs because of the fat redistribution of the OP compound. Okay. OP compound. Because of lack of PAM treatment. Of PAM treatment. Okay. And even in our case, we didn't give PAM. Why? Because patient presented late. And then we thought that why, is there any role of PAM? What should we do now? Because patient doesn't have any other symptoms. But that, because after this intermediate syndrome, then we thought, let's give PAM. Okay. So that's about the intermediate syndrome. Then talking about the OP-induced delayed neuropathy. So OP-induced delayed neuropathy is something which occur after 2 weeks or one to 2 weeks. Okay. So the particular period is 1 to 2 weeks for the OP-induced delayed neuropathy. All right. So symptoms will again here in this case in OP-induced delayed neuropathy, patient will have distal weakness. Okay. So as I mentioned, in case of intermediate, it was proximal. Here it is more distal than proximal. Okay, and here it is more proximal than distal. Now, naturally, just tell me if the disease is presenting earlier and one disease is presenting later, which one out of two you think has a better prognosis? Can anybody tell? Exactly. Earlier one has the better prognosis because you have the option to treat it, isn't it? If the disease present later, like the name suggests, OP-induced delayed neuropathy. So it will be really difficult to manage this condition. But remember, sometimes it also get back to the normal or it may get back to the normal in 1 year period. Okay. So as such, the prognosis is bad over here. Okay. It's bad prognosis and it's get better in almost 1 year period. Okay, so that is about the OP-induced delayed neuropathy. So all these things you will again read while reading the neurology topics, but this is here. This is important to know over here. Coming to the chronic neuropsychiatric symptoms. So some of the times this atropine treatment or even the OP poison can affect the CNS, leading to the chronic neuropsychiatric symptoms, and patient might be depressed for longer duration. Okay, and lastly, if patient has taken so much of OP poison because of cholinergic activity, there can be bradycardia, and therefore first treatment is always atropine. And that's why I also asked in the earlier question that which one you will give. So that was atropine. So this is about the important complication that you should must know in case of OP poisoning. Coming to the next part. So if you guys please can answer this one, it will be really great. So basically we are talking about the mechanism. So this one was the question in the mechanism of action. But I think just to revise the mechanism of action, I just want the answer from you. Okay. So which one will the answer? Exactly. 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 Easy one, but just to cross check. Okay. Very good. Now coming to the clinical examination and what findings will be there in case patient is taking OP poison. All right. So we have very important findings. All of this we know. Right? Bradycardia will be there, hypotension is there, tachypnea is there, and we are all recent to this. So tachypnea is because of the respiratory distress, okay? That is fast respiratory rate or respiratory distress per se, okay? Then patient will have hypoxia, okay? Coming to the respiratory examination, you know, because of the bronchospasm, there will be adventitious lung sound. So if you remember, lung sound are of two types, right? So first one is normal or primary lung sounds, or second one is adventitious lung sounds. So primary includes all the lung sounds, like bronchial and the other lung sounds. But here in case of adventitious, you have this rhonchi, wheezing and all. So what is the cause for this rhonchi and wheeze? That is bronchospasm. And here in case of muscarinic overactivity, you have bronchospasm. So definitely you can expect wheezing. Can anybody tell me what is the difference between rhonchi and wheeze? In the chat section quickly. Rhonchi and wheeze. So I'll just ask leading question. Okay. Exactly. So wheeze is something which is audible without even auscultation. Exactly. Exactly. No, expiratory and all is not the difference. Exactly. Wheeze is something, it's like a whistling sound. You will listen to like this whistling type of sound, typically even without auscultation. And if you're doing auscultation, that has to be wrong kind, right? Then if there is a respiratory failure, there might be some atelectasis, basal atelectasis, which can give rise to the crackles, which will be fine most of the times. Then bronchoria, so increase in respiratory secretion, there can be bronchoria, which can also give rise to the crackles. Okay. And finally, there will be respiratory distress. So how will you understand if there is respiratory distress or not? So you have to look at the accessory muscles of respiration. So what are those accessory muscles of inspiration and expiration? We have sternocleidomastoid, we have trapezius, we have nasal ali, right? And we have internal intercostals. So all these muscles are your accessory muscles of respiration, and that will get activated in case of respiratory distress. So this is about the clinical finding on the respiratory examination. Coming to the neurologic examination. So in neurologic examination, you already know that there is a muscle weakness, okay? Muscle power will be low, obviously. Then muscle fasciculation will be there, okay? Then altered mental stresses, seizures, and coma. So all these things can be there. Just one thing about the muscle fasciculation I want to ask you guys. And how do we check for the muscle fasciculation? The leg has to be in the silent position, or you have to take any other position. You have, you have to put the leg as it is, or you should change the position of the leg. Okay. As such, muscle fasciculation should not be done in the changed position. It has to just observe. Okay, you don't have to change any position of the patient. Okay, so that's why this is important for the examination part. Also, if you're seeing any cases of LM and palsy, for example, you're able to see the tongue fasciculation. You want to see tongue fasciculation. I will show you one of the video. I'll forward to Shubham, and I will probably share in the group also. So, if you have tongue fasciculation, and how do we check that? Do we ask the patient to stick out the tongue, or we just ask the patient to open the mouth? Anybody? Exactly. We just ask the patient to open the mouth. We don't ask stick out the tongue. Okay. So that's how you check the fasciculation. Just the examination finding I want to talk about that. All right. Then about the abdominal examination. So as I've already discussed, there will be increase in motility of the bowel, which will give the hyperactive bowel sounds. Got it? Coming to the last part, that is diarrhea and the abdominal cramps. Okay. Okay. Then there's one more question before going to the lab diagnosis. Can you tell me which is the answer in this case? Okay. So most likely finding to be observed in laboratory evaluation of the OP poisoning patient. Is it increased red blood cell activity? Is it elevated serum potassium? It is increased plasma. It is decreased, or it is increased urine catecholamine. Easy one, right? Correct. So remember, there is a decreased activity because of the OP. Okay, always remember this. Got it? So don't get confused with that. So in laboratory investigations, we have two important things. First is RBC acetylcholinesterase. Second is plasma cholinesterase. But what is the difference between this? So RBC cholinesterase is something which is more specific as compared to the plasma cholinesterase. Therefore, we tend to go to the RBC acetylcholinesterase, because the plasma acetylcholinesterase is something which is easily available and mostly done in the routine test. Okay, so we have RBC acetylcholinesterase, and that will definitely show what? Depressed acetylcholine activity. Even in case of plasma acetylcholinesterase, that will also show decreased levels, and it is less specific, but yes, it also suggests that OP compound is there involved or not. Okay. Lastly, coming to the arterial blood gas, and definitely it will show hypercapnia, right? We already discussed there is a respiratory acidosis, and patient will have metabolic acidosis some of the times, and definitely patient will have hypoxia in these conditions. Coming to the electrolytes, so these patients typically has hypokalemia and hyponatremia. The cause is clearly not known. Okay, so this is one of the important thing that you also should know while talking about the laboratory investigation in this patient. Okay, so coming to the final few parts of the discussion. Okay. So let's discuss. Let's start with the treatment part now. So before treatment part, I want you to answer this question: that which of the sign indicates the adequate atropinization? This is very common question you guys get about the OP poisoning, because patient will come to you, you will start atropine, no doubt. But if you overuse atropine, there can be condition that is called as atropine psychosis, and patient will be pretty much okay. Somebody has mentioned C and D. Somebody has mentioned C, somebody has mentioned B. Somebody has mentioned drying of mouth. So guys, there is only one answer for this, that is C. Okay, those who have written C is the correct. Because according to the Harrison and Maine book, increasing the heart rate is not in the criteria to indicate atropinization. Only drying of the bronchial secretion or improvement of the auscultation of the patient is the important finding. Okay, that is about the resolution of the wheezing. Obviously, you have to give some beta agonist in this patient, but yes, okay, so it is only indicated. Then next would be this, that is improvement in the pupil side. So we were talking about the most important, okay? So most important sign, or like first sign that you should consider, okay? Then this is pupil size. Then gradually you can think of proximal vasa weakness and tachycardia. Okay, tachycardia is never a finding, definitely, because even just 1 minute of atropine can cause tachy. All right, so that is never the criteria. But the first most important is drying of the bronchial secretion. Got it? So now let's discuss the treatment itself. So treatment has typically A, B, C, D, E. All right. So till now you must have learned A, B, C of the treatment. That is airway, breathing, circulation. But what is D and E in this patient? So D is disability or decontamination of the patient. All right. And E stands for the exposure. So whatever chemical substance patient has got exposed over, you just have to wash the patient first. Okay. So let's start with the airway first. So we have to clear the airway, we have to protect it, and we have to do early intubation to secure the airway. All right. Because if patient's consciousness is altered, there might be possibility of the aspiration, and patient may get the aspiration pneumonia. That's why we have to secure the airway as the first step. Second is breathing. We have to check if patient is breathing properly or not. If patient is taking lot of extra effort or patient is tachypneic, then also we have to plan the mechanical ventilation by intubating the patient. All right. So that is about the breathing. We have to provide 100% oxygen to all the patient if patient has hypoxia. That is SpO2 less than 90%. Okay. So that is about the breathing. Then coming to the circulation, we have to check patient's blood pressure. Obviously, if patient is in shock, we start with the inotropic support and make sure we maintain the normal BP and normal mean arterial pressure. Because if we maintain normal mean arterial pressure, there is a less chance this patient gets into the end organ failure. That is your acute kidney injury or other any ischemic hepatitis or any sort, which can occur in case of hypotension or cardiogenic shock. So we have to maintain the normal BP, and we should start IV fluids as the first step. And definitely we might need some inodrops if patient has persistent hypertension. Coming to the disability, so we have to check patient's GCS for that. All right. So we check the GCS, and from that we can get idea that what is patient's sensory. So I'm not going into details of the GCS and all. We'll discuss that when discussing neurology. All right. Then coming to the seizure activity. So how do we check for the seizure activity? So if patient has seizure, persistent seizure is their GTCS mostly. It is commonly seen in OP poisoning. We have to give benzodiazepine then and then. Otherwise, it may complicate the patient's condition. Coming to the exposure. So most of these patients have lot of pesticides on their clothes and all. Okay, so we have to remove this contaminated gluten. So in most of the hospital, if you're working in the corporate hospital, we have one decontamination room, a dedicated decontamination room. So you have to take the patient to that dedicated decontamination room. Okay, it's charging issue. Just a second. I put the charger first. 1 second, guys. So we have to take the patient to the decontamination room and then we have to clean it. But how do we take the patient? So obviously you have to wear the PPE, personal protective equipment, and all these things you should take care. Just a second, guys. All right. So you have to take the patient to that specific decontamination room. You have to wear all the PPEs, all the gloves, mask, and all, and you have to decontaminate patient. You have to wash with this. You have to ask the patient to wash the skin, and if you don't have anybody, then you can wear gloves and all, and you have to wash on yourself. Okay, so that is about this exposure step. So never ever miss this A, B, C, D, E. Okay, so always remember this A, B, C, D, E, which is very important in here. Okay. Coming to the specific antidote and the specific therapy, I've already talked about the atropine and pyridoxine, but let's see the doses now. So typically atropine will reduce all the muscarinic symptoms, isn't it? So the job of the atropine is to act on the acetylcholine receptor itself. So it will go and join the acetylcholine receptor and will not let ACH act itself. Okay. So it will reduce all the muscarinic and nicotinic symptoms. Okay, so here also it is mentioned that to counteract all the muscarinic and nicotinic receptors, we have atropine as the first dose. Okay, but how to give atropine? So it should be given 1 to 3 milligram IV bolus first. Okay, and then we have to repeat every 5 to 10 minutes until bronchoria, bradycardia resolve, and pediatric dose is 0.02 mg per kg. Here we have written bradycardia, but remember bronchoria is the only thing that has to be taken care of. Okay. All right. Okay. Sorry, I've mentioned mistakenly about the nicotinic, but it acts on the muscarinic receptors. So yeah. So it also helps to reduce the muscle symptoms as well. That's why I mentioned that. But in case of prolidoxine, this is something which acts on both muscarinic and nicotinic. Okay. So aspirin, atropine is something which mainly acts on the muscarinic. Thank you for noting. Okay. So atropine acts typically on the muscarinic, whereas prolidoxine acts on both muscarinic and nicotinic receptors. Okay, so as already discussed, then about the pralidoxin, it is available in the market in the form of 2 PAM and how it should be given. So 1 to 2 gram IV over 30 minutes, and it should be repeated every 1 hourly, then every 12 hours as needed. Okay, so pralidoxin reactivates this acetylcholinesterase by removing the OP compound before aging occurs. Okay, which we have already discussed all these things. Got it? So dose is 1 to 2 gram IV over 30 minutes, and then you have to repeat every 12 hours. Whereas in atropine, you have to repeat every 5 to 10 minutes, and the dose is 1 to 3 milligram. All right. Okay. So clinical notes, that's it. We just have to take care of the secretion and the bradycardia. Then similarly here also, if it should be given early, as early as possible, otherwise aging might occur. Okay. So then we have seizure management. Okay. So second, there's issue with the pain. Okay. So in case of seizure management, as we discussed, we have to give diazepam, and lorazepam. So that plays significant role in controlling or stabilizing or reducing the seizures. Okay. So that's about the diazepam. Then lastly, to maintain the patient status, we have to give enough IV fluids. We have to do electrolyte monitoring and stabilizing the patient. All right. So long-term care, how it should be taken. So talking about the intermediate syndrome monitoring, we have to regularly do clinical examination of the patient. We have to see proximal vessel weakness if it's there. We have to see for cranial nerve examination, and we have to regularly quickly check for the single breath count if patient is on the non-ventilator. But if patient is on ventilator, we'll try to wean off and we'll try to give intermittently the pressure support to the patient, so that we have to see if patient is able to trigger or not. Okay, so that's about the intermediate syndrome monitoring. Then neurological assessment, again, by regular neurological examination, you can do that. And lastly, electrolyte and acetylcholinesterase monitoring should be done. All right. So complication prevention. So there are two commonly seen complication in case of OP poisoning. The first is aspiration pneumonia. As I said, the patient has a high chance of that to aspirate the contents, which should be taken care by securing the airway as soon as possible, and to regularly check if patient doesn't get wrapped once intubated. Okay. And lastly, thrombosis or DVT is very important complication which can be seen in the any bedridden patient, because OP poison is mostly takes almost 7 to 14 days, and in such cases you have to give some DVT prophylaxis also, because all of the organs are already damaged. So because of the coagulation, hypercoagulability might occur, and there might be the possibility of DVT and pulmonary embolism eventually. Okay, so that's why you have to take care about the aspiration pneumonia and DVT also. Okay. And lastly, before discharge, you have to take care of the patient's neurological condition and the psychiatric evaluation, because, as I mentioned, there is a high possibility that there is high possibility that patient might have depression for the longer duration. Okay, so that's all. Here is the summary, quick summary. So ABCD approach is there. Then antidote therapy, respiratory support, seizure management, decontamination, and monitoring of the patient. So these are few of the things which have to take care while treating this patient. All right. So that's all about the OP poison in discussion, guys. So I think it was Okay session. You discussed, you got idea about most of the things about the OP as such. So any doubts? Any doubts? Somebody has put about the what about the aging time in different compounds? Does once you've done atropinization. So yeah, this is a good question, Gayatri, that how long to give atropine and PAM infusion. So remember that atropine has to be given till the effects of the atropinization are seen. So which we already discussed. So after that, we have to reduce the dosage. We have to start reducing dosage and we have to stop over a period of 24 hours. And same is with the pralidoxine. We eventually stop it within 48 to 72 hours of use. So one question, good question, Kunal. What about the OP poisoning without toxidrome? Should we give atropine? No, if it is without toxidrome, it is not indicated as such. But to prevent the symptoms, you might be keeping tabs on the RBC cholinesterase in this patient. If you see that RBC cholinesterase is there, then you can give PAM rather than this. Okay, role of magnesium sulfate. Yes, magnesium can be given because dyselectrolytemia is very common in case of OP poisoning, but as such, it is not indicated in the guidelines that magnesium must be given. But depending on the patient's magnesium level, potassium level, if patient has hypokalemia and it is because of the hypomagnesemia, then definitely you have to take care of the magnesium level also. That is one question about once you achieve atropinization, 80% of the total dose is given as a infusion. Yes, you have to give infusion, but only to the certain period, and after that you have to stop the infusion also. Atropine is not indicated for the longer duration. Okay, because of its toxic effect and the atropine psychosis. Any role of clonidine? There is one question. Any role of clonidine? I'm not sure about the clonidine. I'll let you know. Then there is one question about how to differentiate atropine delirium and CNS altered sensorium of OPS effect. So, as such, atropine delirium is something patient will have mydriasis and all. Okay. Whereas in case of OPS, just if we're talking about the OPS, patient will have meiosis, right? So you just have to look at the pupils of the patient and how is the response. So atropine psychosis patient are mostly agitated, whereas OP compound patient are mostly drowsy type of patient. Okay, so this is common change. Atropine patients are quite, you can see psychiatric manifestations are quite severe, but they are aggressive most of the times. Okay, so thanks for your questions, guys. I think we can wind up the session. If you have any doubts, you can any day message me. My contact is already there in the group. I'll share the PPT and then you can just go and revise through that. Okay. All right, guys. So thank you. Shubham, are you there?
Yeah, thank you, sir.
Okay. Thank you, guys. We can wind up the session and I hope you liked it.